I will get started since we have a lot to cover today. Welcome to Grill. Please text the number on the screen with the code GET-CMI for CE credit. There we go. So for those of you who do not know me, my name's Larissa and I'm a PGY1, and I will be presenting on the trials and tribulations of the treatment and prophylaxis of cytomegalovirus. And my contact expert is Dr. Jorgensen, or May. So I have 3 learning objectives for this presentation. First, describe the impact of cell-mediated immunity, or CMI, on cytomegalovirus, or CMV, infection in transplant patients. Second is to identify patients who may benefit from antivirals versus alternative approaches. And third, apply the information learned in this presentation to a patient case. So let's jump right into our patient case. Here is our friend BF that I will be referencing throughout this presentation. BF is a 42-year-old male with a significant past medical history of end-stage renal disease secondary to type 2 diabetes. He's admitted today for a DCD, or donor after cardiac death, kidney transplant. He has an MFI of 2000, which means he is highly sensitized with antibodies to this new kidney. He gets ATG as his induction agent. His CMV serology is donor positive and recipient negative. And for his immunosuppression, his regimen post-transplant includes a dexamethasone rapid taper, tacrolimus, and mycophenolate. So please keep our patient BF in mind. We will come back to him multiple times throughout this presentation. So what is CMV? It is a beta herpesvirus primary infection that is followed by lifelong latency. Our immune system keeps it in check, but it can be reactivated in times of stress or weakened immune system. 50 to 80% of adults are infected by age 40. Most of us don't know if we have ever been infected or not because it causes a mild illness in immunocompetent people. But unfortunately, it can cause symptomatic disease in immunosuppressed patients. So the immune system has a constant interaction with this virus, and it never completely clears the virus. Specifically, CMV T cells have a lifelong interaction with CMV. While the humoral immune system can play a role in fighting this infection, T cells are essential in restraining CMV replication. So if you can go back to school for a second, there are 3 types of T cells: memory, helper, and killer. In the latency phase of this infection, memory T cells are important to keep in high concentration in order to identify when the virus starts to replicate. Memory T cells can quickly activate other cells like killer T cells when needed. So in a recipient negative transplant patient, they would not have these T cells to easily fight the infection. So cell-mediated immunity, or CMI, is this immune response that doesn't involve antibodies. So returning back to our patient BF, he has a few risk factors for CMV. First, he received intense immunosuppression and is continuing to be immunosuppressed by his current regimen. Second, he is in the high-risk serostatus group, donor positive, recipient negative, since he doesn't have those T cells to fight off this infection. And he will be getting a kidney with the virus. Third, he received a T cell depleting induction agent, ATG. So our patient got a transplant. So you may be wondering, for how long should we be worried about the CMV infection post-transplant? Well, studies show that in the first year of transplant is the highest risk for CMV, and then it drops off after then, as you can see in this free survival graph of high-risk pink patients. 1 year after transplant, CMV infection is less than 5%. And patients likely develop cell-mediated immunity by 1 year post-transplant, which is likely why these rates drop off by then. Additionally, we see higher rates of CMV after rejection, and that is likely since patients receive intense immunosuppression again and can lose cell-mediated immunity. So CMV disease is an independent risk factor for graft loss and mortality in transplant patients. Serostatus at transplant is the most important risk factor for CMV disease. So to prevent these negative outcomes, we provide prophylaxis during this high-risk period post-transplant. So I want you to think about our patient BF and what prophylaxis would be best for him while we go through the options. Again, the goal of prophylaxis is to prevent negative graft outcomes. If the goal was just to prevent or treat the infection, that would be very easy. We would withdraw immunosuppression, and CMV is no longer a clinically significant issue, but then we would lose our graft. This is unique to solid organ transplant versus stem cell transplant. These patients require a balance between rejection, prevention, and infection risk. There are two approaches to prophylaxis: universal prophylaxis and preemptive monitoring, or PEM. Universal prophylaxis is covering everyone with antivirals for 3 to 6 months post-transplant, depending on their risk status. We have a guideline here, which many of you have probably seen before. This table is from the UW guidelines, which lays out exactly what to prophylax with and for how long, depending on the induction agent and serostatus. And I just want to point out here that Cyclovir does not work against CMV. This is for herpes simplex. And the benefits of this approach is that it's easy to follow and it's not time intensive. PEM, on the other hand, involves monitoring patients' CMV viral loads while they are not on prophylaxis and watching for any early replication. Once there is replication, antivirals can be started early to prevent symptomatic CMV infection. Some studies have shown that there is a lower incidence of CMV disease on this approach than universal prophylaxis over a 12-month period. Benefits of this approach include less drug exposure, therefore reduced resistance, less leukopenia from Valgan Cyclovir, and immune priming resulting in CMI. And lastly, there have been studies showing less late onset CMV, defined as a CMV infection greater than 1 year after transplant, on this approach, likely due to the development of CMI. However, it is labor intensive. It does not avoid the use of Valgan Cyclovir altogether, as it is needed for preemptive treatment, and patients have a possibility of rapid replication if labs are missed. So what do we do at UW? We use both approaches. We use universal prophylaxis in all patients for the first 3 to 6 months after transplant based on their serostatus. Then we use we only convert high-risk patients' serostatus, donor positive, recipient negative, to surveillance after 3 months or after 6 months, and they get surveillance for 3 months in kidney transplant patients, which is biweekly monitoring of CMV. We convert patients to PEM who develop any intolerance, such as leukopenia from Valgan Cyclovir, or patients who cannot afford their Valgan Cyclovir. So returning back to our patient BF and his prophylaxis. He just got a transplant, so we will do universal prophylaxis in him like we do for all patients. Here is the UW Health Guideline for reference. And he received ATG. He has high risk serostatus. Therefore, he will receive Valgan Cyclovir for 6 months. But remember, Valgan Cyclovir is renally adjusted. This is the insert from Lexicomp. His creatinine clearance is 52. Therefore, he should be getting the 450 milligrams daily. So now it's May, 1 month later, and he presents to clinic with labs. His white blood cell count is 1.9 and his ANC is 800. So what's happening here? He is developing leukopenia from his medications. Mycophenolate, Bactrim, and Valgan Cyclovir all can cause leukopenia. In the inpatient setting, we use the ANC cutoff of 500 for GCSF. In the outpatient setting, we can give GCSF if the ANC is less than 1,000, based on trend and ability or lack thereof to withdraw the offending agent. So I have a question for you all. What would be the most appropriate medication adjustment at this point? And you can put your answers in the chat. I'm seeing a lot of E's, so awesome. A+ for you all. And I'll just review the answers. A is wrong. We do not want to underdose valsite. That could lead to resistance. B is correct. Leukopenia isn't going to improve without any medication changes. C is also correct. We want to give GCSF, but we wouldn't want to only give GCSF because likely his leukopenia would come back. And D is wrong. Patient is highly sensitized with the MFI of 2000. So decreasing mycophenolate at this point could lead to rejection. So the answer is E. And given his high-risk serostatus, he is at high risk for rapid replication of CMV. So we need to monitor viral loads closely on PEM. As you may have picked up by now, there are many issues with universal prophylaxis. The key problem with prophylaxis is that Valgan Cyclovir is not a benign drug. We don't want people on it forever because patients on Valgan Cyclovir for greater than 6 months will likely develop leukopenia, and the increased duration of therapy increases the risk of resistance. Valgan Cyclovir prevents CMV while on it, but once the patients are off Valgan Cyclovir after 6 months period, delayed onset CMV still commonly develops. And extending the duration of prophylaxis has not been consistently effective in reducing late onset disease. Due to the potent inhibition of replication, CMI does not appear to develop while the patient is suppressed with Valgan Cyclovir. And lastly, when patients' renal function dramatically changes, which is common after renal transplant, there's a possibility for underdosing, which can increase the risk of resistance. So overall, it would be nice to start something for prophylaxis without myelosuppression. Lucky for us, there is Cytomegalovirus. Cytomegalovirus is FDA approved for CMV prophylaxis in stem cell transplant patients, but not yet approved in solid organ transplant. It is not associated with myelosuppression and it is a DNA terminase complex inhibitor. It does not require renal dose adjustments as it is hepatically cleared. The dose is 480 milligrams daily, and the side effects are mild, and if present overall, it's very well tolerated. Of note, it does have a significant drug interaction with tacrolimus via inhibition of CYP3A4, requiring a 50% empiric dose reduction. So a little bit more about letermovir. At UW, although it's not FDA approved yet, we try to use letermovir in certain patients. If high-risk patients develop leukopenia on Valsite, we prefer to convert them to letermovir, but continue them on surveillance since there can be breakthrough CMV on letermovir. 30% in BMT, that breakthrough rate is 30% in the BMT studies, but it appears to be closer to 10% in solid organ transplant. For solid organ transplant in UW health patients, there was a study here that showed letermovir conversion was associated with the development of CMI in high-risk patients. The etiology of this is not completely clear, but it likely relates to the lack of immunosuppressive toxicity paired with the potential low-level priming on suppression. So since letermovir is not FDA approved for solid organ transplant yet, it is pretty difficult to get insurance to cover it for our patients. But let's try to get letermovir for our patient BF. So he has Quartz insurance. So we submit a test claim in PA like we normally do. And the PA comes back 72 hours later and is denied. And insurance allows for an appeal, and they give us 30 days for this appeal. So we write up a very long, wonderful letter to insurance about why it's important for our patient. Insurance can review it for up to 30 days. And of note, insurance can have secondary appeals, which prolongs this process even further for 30 more days. In the meantime, patients can have replication. And so 30 days go by later, and after all of this, it's still denied. So now, since we've been through all the process of appeals, we can now apply for a patient assistance program if the patient makes less than 5,000 or 500% of the federal poverty limit. So in order to apply for PAP, you must go through all levels of appeal first. And after all of that, our patient makes too much money and cannot afford the full price, therefore will go without and be continued on PEM. So our patient is on PEM. He now presents to clinic for labs. His viral load is now 320, which, as you may know, is low-level replication. There are a few things I want to point out here. There is no absolute viral load that necessitates treatment, and low-level CMV viral load is not tied to negative outcomes. But our patient is in the high-risk serostatus group. He's in the first year of transplant, and his lymphocyte count is less than 610. In the literature, these are risk factors that are associated with rapid viral progression. And we need to consider risk factors for rapid viral progression when deciding to start antivirals in PEM. We would want to start preemptive treatment here with Valgan Cyclovir 900 milligrams twice a day. Now, if you look at LexiComp, the cutoff for dosing adjustment is 60. At UW, we do a soft cutoff around 55 or 60, and here's why. So first of all, Valgan Cyclovir dosing is extrapolated from Ganz Cyclovir dosing. So the same thing applies to Valgan Cyclovir. Standard IV Ganz Cyclovir is 5 mg per kg Q12. However, doses of 10 mg per kg can be used. And in a study at UW, a 7-day course of IV Ganz Cyclovir, loading period of 10 mg per kg Q12 in high-risk patients with primary CMV resulted in improved viral clearance kinetics without any safety concerns acutely. So that is why we dose aggressively up front in treatment, specifically in patients without CMI and in high-risk serostatus group. So basically, we can take the LexiComp dosing guideline and adjust the doses up one row as I did here. Moving on to treatment. 1 week later, after BF had that viral load of 320, he calls his coordinator with diarrhea and fatigue. He was unable to start Valgan Cyclovir due to medication delivery delays from the pharmacy. His viral load is now 18,000. He mentions that he does not want to come into the hospital if at all possible. So a few things I want to point out here. There is no absolute viral load that is correlated with severe CMV disease, and there's no absolute viral load that necessitates treatment with IV Ganz Cyclovir. In a study of kidney transplant recipients who received late onset CMV disease, the peak viral load in symptomatic patients ranged from 400 to 2 million. So I have a few questions for you all to think about. Does he have CMV disease, and can we keep him out of the hospital at this point? So let's differentiate the difference between disease and infection. So CMV infection is the presence of CMV replication in tissues, blood, or other bodily fluids, regardless of symptoms. CMV disease is the CMV infection with clinical signs and symptoms, which is categorized into two different things. First, CMV syndrome, which typically manifests as fever, malaise, leukopenia, thrombocytopenia, and elevated hepatic transaminases. And end-organ CMV disease affects an organ, typically the organ that was transplanted, such as nephritis, myocarditis, and pancreatitis, and so on. The Victor study compared IV versus oral Valgan Cyclovir. They found that a viral load of less than 10,000 copies per milliliter, oral Valgan Cyclovir was non-inferior to IV Ganz Cyclovir. Things we want to consider when deciding if oral is adequate for treatment include severity of symptoms, patient preference, adequate oral absorption, and intralaboratory variability. So 10,000 does not mean the same thing at all labs. Absolute viral loads are very variable at different labs. So we should base our judgment more on symptom improvement rather than absolute viral load. And lastly, like I mentioned previously, Valgan Cyclovir dosing is extrapolated from Ganz Cyclovir in patients weighing 50 to 100 kilos. Therefore, patients greater than 100 kilos are more at risk for breakthrough infection, and patients less than 50 kilos are more at risk for toxicity from oral Valgan Cyclovir. So back to my questions. Does he have CMV disease? Yes, he has leukopenia, CMV viremia, and symptoms. And second question, is oral okay, or do we need to admit him for IV therapy? I think oral is okay at this point since he hasn't really started it in the first place. He prefers not to come in. And lastly, a viral load of 18,000 doesn't have significance to us for this question. So overall, the goal of treatment is to encourage cell-mediated immunity for our own immune system to fight the infection. It's a dual approach with antivirals and immunosuppressive modifications. All CMV can be cured with immunosuppression withdrawal, but rejection and graft failure would be likely. So we monitor CMV viral loads weekly on treatment and watch the trend rather than the absolute viral load. Our options for treatment include Valgan, Cyclovir, Ganz, Cyclovir, and reducing immunosuppression. In the guidelines, it's preferred to use IV Ganz Cyclovir over oral for tissue invasive disease, severe symptoms, and requiring hospitalization. So back to our friend. He gets labs 1 week after starting Valgan Cyclovir, and his viral load is now 10,000 or 100,000. So it went up a lot since last time, and he continues to have diarrhea. So one thing I want to point out here is that viral load can continue to increase even after starting treatment. So my next question for you all to think about at this point, can we keep him out of the hospital still? So one thing we haven't done yet for BF is reduce his immunosuppression. We didn't do this for prophylaxis due to his high MFI, but for treatment, it can be considered. Reducing immunosuppression will aid in the development of CMI. And studies show that the development of CMV T cells results in a reduced risk of rejection and protection against high viral load. There is no guidance in terms of how to reduce immunosuppression since it is patient-specific. Moving on to adjunctive therapies, IVIG can be considered in the guidelines. It slows the spread of CMV by neutralizing the virus, and it appears to be more useful in the setting of primary infection. The dose is 500 milligrams per kilo once weekly for up to 3 weeks. So back to our question, can we keep him out of the hospital? I think we can at this point. We can hold his mycophenolate and give IVIG. And this is because his lymphocyte count is 210. Usually we wouldn't go to holding mycophenolate right away, but according to the guidelines, reducing an immunosuppression is strongly considered in solid organ transplant with severe lymphopenia and those with deficient CMV T cells. Now another week goes by and his viral load is now 600,000. He has a new fever, poor PO intake, and worsened diarrhea. So next question for y'all to put in the chat, what would be the most appropriate next action? So I'm seeing a lot of A's, which is awesome. We should admit him at this point and start IV Ganz Cyclovir. B is incorrect because we already held the mycophenolate. C is incorrect because we already gave IVIG and likely will not help in the long term. D, Tribulations is incorrect because it's only used for prophylaxis and is only recommended in viral loads less than 1,000. So you're probably wondering what the guidelines have to say about CMI testing. So there are no strong recommendations about testing or modifications based on CMI in the guidelines since it's fairly new. At UW, we do a few things with CMI testing. So testing is typically done at 9 months post-transplant in high-risk patients, and that outcome determines surveillance post-prophylaxis period in high-risk patients. There are a few types of CMI tests. There's ELISA, and flow cytometry. At UW, we use the Viacor CMV T-cell immunity panel. It's a send-out lab, and the turnaround time is around 7 days. It has a high positive and negative predictive value, and it does require an absolute lymphocyte count of 400 to 800 per the manufacturer. And in terms of interpretation, it is a quantitative assay reporting out both CD4 and CD8 cells as a percent of all circulating T cells. A percent greater than 0.2 is correlated with CMI. And there's also a control that's reported as staphylococcal enterotoxin B, which should always be positive. So if a patient is not responding to treatment after 3 to 4 weeks, it's recommended to test for resistance. So fast forward a little bit, our patient has since discharged from the hospital. Here is his viral load trend. As you can see, it trended down nicely after discharge. Then all of a sudden, it starts to increase. He was discharged on 900 milligrams BID of Valgan Cyclovir. He was taking it as prescribed, and then as he started to have low supplies, he started rationing it and started taking only 900 milligrams daily. So we test for resistance, and he has the UL97L595S, which is a mouthful, gene, which is a high resistant mutation. And he does have some risk factors for resistance I want to point out. First, we were underdosing the Valgan Cyclovir. He was taking it incorrectly, and his renal function has improved. Second, his weight is greater than 100 kilos. Like we mentioned earlier, Valgan Cyclovir is extrapolated from Ganz Cyclovir. And third, he's immunosuppressed and does not have CMI. Oh, sorry. Last thing I wanted to say here, another risk factor for resistance is prolonged use of Valgan Cyclovir, which is greater than 6 weeks. It hasn't been quite that long for him yet. So at this point, I know we haven't covered all of this yet, but what would be the most appropriate next step? So I'm seeing C, which is awesome. We would want to give Foscarnet and admit him at this point. A is incorrect. Like I said earlier, the Cytomegalovirus is for prophylaxis when viral load is less than 1,000. B is incorrect. We can increase the Ganz Cyclovir dose for low-level resistant mutations, which I'll get to in future slides. C is correct, and D, IVIG won't help in this case. So our patient gets admitted for Foscarnet therapy. So treatment of resistant CMV is multimodal. It includes Foscarnet, Maravavir, IVIG, and immunosuppression reduction. So we will dive into more details in later slides of each of these. So I want to review Foscarnet first. Foscarnet is not a fun drug. If we need it, we should use it as short as possible, especially in our kidney transplant patients. It's very toxic to the kidneys, and it can be a graft-ending drug in kidney transplant. And it also causes leukopenia. It is a non-competitive inhibitor of viral RNA and DNA polymerases and HIV reverse transcriptase. It's dosed at 60 mg per kilo per dose every 8 hours or 90 mg per kilo per dose every 12. And of note, there are renal dose adjustments. For adverse events, it includes severe electrolyte abnormalities, and we usually replete electrolytes multiple times a day for these patients on Foscarnet. It can also cause renal impairment, headaches, and genital lesions. So back to our patient, he's now on day 7 of Foscarnet therapy. He has painful genital lesions. His renal function is worsening, all probably from the Foscarnet. So, however, his viral load is improving. It's now 8,000. So what can we do next if he's having phosphocarnet toxicity? Luckily for us, we have Maravavir. Maravavir is FDA approved for refractory CMV treatment. It inhibits the UL97 protein kinase. It's dosed at 400 milligrams twice a day. And the most common side effect would be a metallic taste, but it can also cause diarrhea, nausea, and fatigue. There are no renal dose adjustments. And in terms of drug interactions, it is a CYP3A4 major substrate, so our typical inducers and inhibitors of CYP3A4 would be interactions. And the biggest thing, it's not associated with myelosuppressive toxicity. So let's quickly review some data on Maravavir. In the phase 3 trial of Maravavir, it showed a confirmed CMV clearance of 56% compared to 24% in the investigator assigned group. The majority of patients had a viral load of less than 100,000, which is why we typically start phosphocarnet first line in our patients and then transition them to Maravavir. Previously, we would have to keep patients in the hospital on phosphocarnet until the viral load was undetectable, but this helps get people out of the hospital quicker. However, it does have a black box warning for virologic failure, meaning it doesn't work sometimes, which is why it's kind of used as like a crutch or a Band-Aid to help patients' leukopenia recover and foster cell-mediated immunity. So back to our patient, we should start the process of Maravavir approval, ideally right at admission, but since this hasn't happened yet, we will do that now. And if not already involved, we should consult CMV ID stewardship. So we file a test claim like normal. Test claim comes back at $4,000. Patient cannot afford that. So we fill out the Takeda Patient Assistant Program form, and they should take care of the rest. So we should always fill out this paperwork and have the patient sign it if we have any inclination that they may need it at some point. The process for Maravavir, while involving a lot of paperwork up front, is generally much easier than Letermovir, since it's actually FDA approved for this indication. So while we're filling out the paperwork, an order for Cytovir comes through. So I'll review these other alternative agents briefly. So Cytovir is not used here because of nephrotoxicity, ocular toxicity, and high failure rates of CMV clearance. High-dose Cyclovir, as I mentioned previously, can be used for certain low-grade mutations, such as the ones listed in this table in red. Leflunomide is also not used here because it has a half-life of around 19 days and it's immunosuppressive. So back to our question, what do we do in this case if a Cytovir order comes through? We would want to talk to the provider about our plan to get Maravavir, especially since his renal function is worsening and Cytovir would not help that. So to wrap up our patient, we can fast forward 8 weeks. He's now back in clinic for his follow-up appointment and he feels great. He's been on Maravavir for 8 weeks and wants to know if he can stop it yet because he doesn't like the metallic taste. We get his CMV T-cell panel back and it shows this. So here in red, it shows the CD4 and CD8 cell count percentages. So his say greater than 0.2%, meaning Cmi. So we could keep him on Maravavir prophylaxis for a bit longer, but now that he has Cmi, his risk for recurrence is reduced unless he were to get rejection and receive more intense immunosuppression. So hopefully this is the end of CMV for him. but there's still a lot we don't know about future resistance. So for main takeaways, CMV should be treated in a holistic approach that fosters CMV, CMI, and letermovir and possibly maravavir may improve the development of CMI when compared to Cyclovir derivatives. So thank you all for listening to my presentation, and a huge thanks for May for being my contact expert. So I'll open up the floor to any questions. And here's the code again.
Hey, Larissa, can you hear me?
Yes.
So thanks a lot for the great presentation. I was wondering, is there any conversion between Valgan Cyclovir and Ganz Cyclovir that you could use to kind of eyeball the dosing for those high or low body weight patients? I'm assuming it's not 1-to-1.
It's definitely not 1-to-1. And I don't have like a good rule of thumb off the top of my head because Ganz Cyclovir is weight-based dosing. So I'll have to get back to you on that.
Yeah, we kind of, this is May, we kind of, if they're greater than 100 kilos and, you know, their creatinine clearance is like a strong 50, we round up to 900. But if you're just being like, you want to eyeball the IV GAN dose and think about what the oral valsite dose is, 2.5 mg per kg is like the 450 and 5 mg per kg is the 900 dose. But again, these were extrapolated in the study only for weights between 50 to 100.
Okay, yeah, that's kind of helpful. I guess I'm thinking for our patients who are right on the borderline for like creatinine clearance cutoffs.
Right. So we'd round up.
Yeah.
But I mean, we had a significant problem with resistance back in like 2015. So we round up in most cases. And if people have toxicity, we convert them to PEM because we found, you know, this underdosing was a unifying risk factor among all patients. And I mean, I say underdosing loosely because it was appropriate renal dosing in some settings. But yeah, we're a little heavy-handed.
Yeah, and I don't think we have quite as much resistance on the stem cell transplant side, and we do have flow count problems frequently, so I don't think we're quite as heavy-handed with it.
Right, and theoretically, you know, the overall risk for your patients could, you know, get better with their immune system recovering. But for ours, you know, there's always a balance. And not everyone, you know, will mount CMI.
Any other questions? Thank you all. I can stick around for any questions if there are any more.
Hey, sorry, Larissa, one more. I think you mentioned letermovir can be used for CMV less than 1,000. Can you just speak a little bit more to that data?
Yeah, so when reviewing the data, letermovir is only used for prophylaxis, and I didn't find any data on like treatment dosing. So it can be used less than 1,000. That's kind of the cutoff around there. And then Maravavir's cutoff is less than 10,000. And that's because most patients had a viral load of less than that in the clinical studies.
Yeah, so for letermovir, that's based on its use in treatment for GAN-resistant CMV. They found if the viral load was greater than 1,000, the patients did not have, you know, any positive outcomes. But if it was less than 1,000, they could. The thing you have to remember about using letermovir when there's detectable replication, like a quantifiable viral load, is the fact that it has this alternative mechanism of action. It's a terminase inhibitor, which allows like the virus to build itself and therefore be detected in PCR, like molecular diagnostics, but it's not clinically relevant virus because it's been, inactivated. So you'll get a rebound viremia. So let's say we have a patient, before Maravavir, we used to convert anyone with GAN resistance to Letermovir at this lower viral load. So their viral load's like 300 or something like that. You start Letermovir, and then a week later, the CMV PCR is 7,000. So this is common and happens in like 100% of the patients because of this alternative mechanism of action. And the key thing to remember is not to like freak out. You just keep the Letermovir going. Their white count recovers, and then the viral load trends down because, after a while, the virus isn't building itself anymore because it's all inactivated.
So, wow, that's fascinating. So, is it kind of like our Valcyte then, just from the perspective of whenever you kind of initiate the Letermovir, you have to give it a week or two before the viral load reflects what the drug's actually doing?
I would say it's so like the Valcyte, you wonder about like the upward trend of these people's viral replication. So you're talking about like you start them on oral Valcyte and it takes 2 weeks or so to see like the impact. But the thought of that is that they have such rapid replication rates in primary CMV that they're like, it gets way out of hand like that. But letermovir is different. It's not that it's a falsely elevated PCR. Does that make sense? Like for Valcyte, that is their actual viral load, and the virus at that level is, clinically significant. So, I mean, in that setting, it goes up 1 week. So, I guess to back up, with our high dose Cyclovir protocol, we don't see that anymore. So, when we do the 10 mg per kg that Larissa presented, we have a 1 log reduction at week 1. But in the outpatient setting, if somebody's on PEM and something happened, they missed a viral load and they're a little bit on the high side when we catch it, then we'll see this like delay to response. But we treat it as something that you need to worry about. So we start lowering mycophenolate. We start holding mycophenolate if it's been 2 weeks. Give them IVIG. We react to it. Whereas the letermovir, you don't need to react. The only thing you need to make sure is that you adjusted their TAC enough so they don't go super therapeutic.
Okay, that's really helpful. And then, like, from a scope of like how, because for our perspective, we're usually starting this, whenever people have completed their Valcyte treatment, and then they're honestly switching back to like secondary prophylaxis. So
Right,
would
right.
you?
So secondary
So you wanted to.
prophylaxis is like a real niche for letermovir. It hasn't been studied per se. I mean, besides that like case series from our center. But yeah, it seems to be like the best of both worlds. You treat them with Valcyte down to something less than 1,000, convert them to letermovir for 3 months, check the T cell immunity to see if they have CMI, and then, you're able to withdraw. And it is effective as compared to like Valcyte secondary prophylaxis, which just delays the problem.
And so in that situation where you have someone with a CMV level less than 1,000 and you start letermovir, would you still expect that increase or that laboratory but like non-functional increase?
Yes, always. So that's
Okay,
like
that's
when
helpful.
letermovir gets approved, like for solid organ transplant, I know that is one of the big issues they're concerned about, that people will like, toss the drug aside because they're like, wow, it doesn't work, because of this blip. But I mean, a blip is sort of like an understatement because it is a pretty high rebound.
It's very useful. Thanks a lot for that.
But that's not to say, I mean, you should always proceed with like, some small degree of concern, right? Because there is breakthrough is possible. We've seen it I don't know, do you guys see it over there? We see it in like patients who have, immunosuppressive intensification around the time of conversion. Sometimes they fail, like particularly the use of belatacept seems to be a risk factor for letermovir breakthrough. I mean, sometimes we're able to withdraw belatacept and return to letermovir and it still works. So even with its low genetic barrier to resistance, I don't know that I've ever seen one that was resistant that we confirmed on, genotyping.
See, I think we would come across that in our GVHDers who are getting started on, 1 mg per kg of pred. Of course, normally they just reactivate at that time, but like I guess we would worry about like a resistance if we try to convert someone to letermovir when they're still on 40 milligrams of prednisone or something like that.
Yeah, it definitely that's why it's kind of a cool drug. It has its own little space and it's certainly not as efficient at preventing replication as Valcide is. I mean, that will prevent it completely. But the fact that it's kind of like maybe less of a good drug is actually its benefit in so much as then, these patients get this low level priming, which is like, the golden star of CMV prevention is low level priming. And yeah, if that's really what's happening, then, it will revolutionize CMV and solid organ transplant.
Great. If there are no more questions, we can wrap up. But thank you all for listening today.